So it is a 19-year-old young gentleman with a good premorbid state. He's non-smoker, social drinker. He had a history of muscle pain and weakness in July 2013 at the age of 13. Previously, he was seen by pediatrics and found to have hypercyclemia with CK level more than 800. While other investigations, including liver renal function, thyroid function, plasma amino acids, lactate, metabolic screen, and carnitine were all normal. His diagnosis at that time was suspect myositis. However, he defaulted follow-up afterwards, and no further investigations were performed. And he was admitted in January 2020 for bilateral lower limb weakness with 3 to 4 days history. Previously, he was able to walk unaided. However, he had progressive limb weakness, leading to difficulty in walking with failed episodes. He also had mild bilateral upper limb weakness without sensory complaints. He did not have back pain or preceding trauma. He did not have sphincter disturbances, no myalgia, no skin rash or arthritis, no facial involvement. He had normal speech, normal swallowing, and normal vision. He did not have fever, and he did not take any other over-the-counter medications, and he had no family history of similar problems. So for examination, for the CNS exam, the patient did not have myopathic phase, no itosis, no fatigability on sustained upward gaze of the eye. And the eye extraocular movement, eye movement was intact without diplopia. He did not have facial asymmetry, and his speech was normal, and he did not have tongue fasciculations. For the PNS examination, the patient did not have limb muscle wasting and no muscle fasciculations. He did not show myotonia and no skin rash. For the limb power examinations, for bilateral upper limbs, the patient showed full shoulder abduction and adduction power. There was mild weakness over the elbow flexion and extension with a power grade 4, while the wrist and fingers power were full. The upper limb jerks were normal and no ataxia was demonstrated. And the sensory was intact in terms of pinprick, light touch, and proprioception. For the bilateral lower limbs, there were weakness over the bilateral hips and knee flexion and extension with a power grade 3-, while the ankle and toe dorsiflexion and plantarflexions, the power were full. And the lower limb jerks were all normal and no ataxia, and also the sensory was intact. So what are the differential diagnoses in your mind for this young gentleman presented with 3 to 4 days history of limb weakness, predominantly affecting the proximal parts of the body with a normal sensation and normal reflex? So maybe I will give you my list of differential diagnoses. The top differential, myopathy, giving the proximal muscle weakness with normal sensory. And there is a long list of etiologies, including inflammatory, infective, toxic, metabolic, endocrine causes. And to work for the diagnosis of myopathy, of course, we could check the blood for the muscle enzyme, CK level, perform EMG to look for any myopathic changes, and even muscle biopsy to look for specific etiologies of myopathy, for example, inflammatory myositis. Next differential diagnosis, chronopathy, for example, periodic paralysis. But we have to see the duration of the limb weakness, because for periodic paralysis, the limb weakness will usually resolve within few hours or up to few days. And so clinical presentation is very important for this diagnosis. The next differential, neuromuscular junction disorder like myasthenia gravis. But our patient did not present with fatigability on clinical presentation or examination. And for MG, usually there may be extraocular muscles involvements or bulbar muscle involvements, but our patient did not have ptosis, and the eye gaze movements were all normal and no bulbar symptoms. And for working for the diagnosis of MG, of course, we could check the blood for MG marker like anti-acetylcholine receptor antibody or striatal muscle antibody, perform the RNS, repetitive nerve stimulation test, or even single fiber EMG for the diagnosis for MG. And next differential, acute motor neuropathy. For example, acute inflammatory demyelinating polyneuropathy or porphyria. But our patient, for this differential, usually patient may have hyporeflexia or areflexia for the diagnosis for neuropathy, but it was absent in our patient. Nerve conduction study can help us make this diagnosis. Next differential, narcolepsy with cataplexy, which is less likely in our case because our patient did not present with excessive daytime sleepiness, which is a typical feature for narcolepsy. And for cataplexy, the limb weakness onset or attack should be much more acute, usually within few seconds to few minutes. Unlike in our case, the limb weakness lasts for a few days. And for cataplexy, commonly there will be facial muscle or neck muscle weakness involvement, but it is absent in our case. So for the we asked for further history. The patient actually had repeated episodes of transient muscle weakness since age of 13. He had minor attacks around 3 to 4 times per month, in which he needs support to get up from bed in the morning, but he was still able to walk or climb stairs. And he had severe attacks 3 to 4 times per year, in which he had difficulty in walking and may need to stay in bed. But the limb weakness resolved spontaneously within few days, and he remained well between the attacks. And this time, the patient did not have specific triggering factors, for example, vigorous exercise, stress, or high carbohydrate diet. And we proceed to the investigations. We perform imaging for these patients, including CD brain, chest X-ray, and LS spine X-ray, which all showed normal findings. And the ECG showed normal sinus rhythm. For the blood test, we checked the CBC, liver renal function, calcium phosphates, which were unremarkable, except there was mild hypokalemia with potassium level 3.4 on admission. But this level may not reflect the exact potassium level at presentation because the patients had the symptoms 3 to 4 days before admission. We also checked for the muscle enzyme CK level, which was normal, with the while the file function, B12, syphilis serology, unremarkable, and there was mild folate deficiency, but it may not correlate to the clinical presentation. And the inflammatory markers and autoimmune markers were all normal. Lactate level was normal. The MG marker was negative, and the urine toxicology was negative. As we think this case may be a case of neuropathy, myopathy, or myasthenia gravis, so we perform the electrophysiological study, including nerve conduction study, EMG, and repetitive nerve stimulations test, which all showed normal findings, making the differential of neuropathy, myopathy, or MG less likely. And for EMG, we performed, it did not show myotonic discharge. So the remaining most likely diagnosis for our case is periodic paralysis. So how can we confirm this diagnosis? we perform a specific test, which is a long exercise test. Actually, it is similar to our usual nerve conduction study in which we perform routinely. And by recording the ulnar nerve and stimulating the ulnar nerve and record the ADM muscle, the adductor digiti minimi muscles, with a preceding exercise for 5 minutes. And this two diagrams shows the result. Maybe we focus on the table over the left side and over this column, the amplitude, in which before the exercise, we take a baseline CMAP amplitude for the ADM muscle, which is 7.1 millivolts. And then we instruct the patients to perform exercise over the ADM muscle for 5 minutes. And we check the CMAP amplitude, which is 10.1 millivolts immediately after the 5 minutes exercise. And then we will allow the patient to take rest and repeat the CMAP amplitude at different time interval, including 1 minute, 2 minutes, 3 minutes, and up to 40 minutes. And we can see there was the decline in the CMAP amplitude from 10.1 millivolts immediately after exercise, dropped down to 3.8 millivolts at the end of the exercise. And this shows 62.4% decrement in the CMAP amplitude. While more than 40% decrement of the CMAP amplitude means it is a positive long exercise test, and which is highly suggestive of periodic paralysis with a specificity up to 100%. So for the progress of our patient, we correct the hypokalemia, giving the potassium supplement, and his limbs powers, including upper limbs and lower limbs, returned back to normal 2 to 3 days later. So for our case, our presumably diagnosis is hypokalemic periodic paralysis. It could be a sporadic case in the absence of family history. And our patient was started on acetazolamide for prevention of attacks, and he was referred to a genetic clinic to check for any associated genes. And he was also advised to avoid precipitating factors, for example, vigorous exercise, stress, or high carbohydrate diet. And for our follow-up progress, the patient had one episode of mild bilateral lower limb weakness in July 2020 without preceding triggering factors. Actually, he did not quite comply to acetazolamide, in which he missed the drugs 1 to 2 days per week. And he had another episode of forelimb weakness in October same year after playing computer games which involved intensive exercise for 1 to 2 hours. And for these 2 episodes, the mild limb weakness completely resolved in few days. However, our patient defaulted genetic clinic in January 2021 and defaulted follow-up in March. And he did not have further AED admissions since March 2021. So today our discussion is on primary periodic paralysis. It is a rare autosomal dominant genetic neuromuscular disorder which involves mutations in the skeletal muscle, sodium, calcium, or potassium channels. By reducing the muscle membrane excitability, which can lead to susceptibility to episodes of paralysis. And there are 3 main types of primary periodic paralysis. The most common one is the hypokalemic periodic paralysis. The prevalence is around 1 in 100,000. And the most common genes involved is the CACNA1S gene affecting the calcium channel, which contributes around 60% of the cases. And the less common gene involved is the SCN4A gene affecting the sodium channel, which contributes around 20 to 30% of the cases. And the next type of primary periodic paralysis is the hyperkalemic periodic paralysis. The prevalence is around 1 in 200,000. And the gene involved is the SCN4A gene affecting the sodium channel. And the most rare form of the primary periodic paralysis is the Anderson Tawil syndrome. The prevalence is around 1 in 1 million. And the common gene involved is the KCNJ2 gene affecting the potassium channel. For the pathophysiology, in all types of the primary periodic paralysis, there is aberrant depolarization, which inactivates the sodium channels and leads to muscle membrane inexcitability. For example, in hypokalemic periodic paralysis, almost all the mutations occur in calcium-sodium channels occur as the arginine residues in the fourth transmembrane segment of the voltage sensor domains. And this segment translocates through a gating pore in the channel protein, causing it to conduct ions at rest. And in hypokalemic condition, the repolarization potassium current becomes small, so the net balance may shift to depolarization and causing the sodium channels to switch to inactive configuration and making the sarcolemma inexcitable and leads to muscle paralysis. And this table shows the clinical presentations of 3 types of primary periodic paralysis. For hypokalemic periodic paralysis, the age of onset usually range between 5 and 35 years old. And that in hyperkalemic periodic paralysis, the age of onset usually before age 20, usually in adolescence or young adulthood. Or that in Andersen-Tawil syndrome, age of onset range from 2 and 18 years old. And the duration of the limb weakness, it is usually longer in hypokalemic periodic paralysis, lasting more than 2 hours, up to a few days. While that in hyper-PP, the duration of weakness is shorter, usually within 2 hours. And usually there is myotonia, either clinically or detected in EMG in case of hyperkalemic periodic paralysis. But myotonia should be absent in hypokalemic periodic paralysis or Andersen-Tawil syndrome. And the muscle weakness is usually more severe in hypokalemic periodic paralysis compared to hyperkalemic periodic paralysis and Andersen-Tawil syndrome. And specifically for Andersen syndrome, the patient may have characteristic faces. For example, wide space eyes, small mandibles, and they may have cardiac arrhythmia, for example, long QT arrhythmia. And for the diagnosis, it can be confirmed by genetic testing, but only 60 to 70% of the cases, we can identify the associated genes. And the associated genes I've just mentioned, so I just skip this part. And as the genetic test is not easily available, and usually when we refer the patient to the genetic clinic, it may take more than 1 year, sometimes up to 2 years to before the patient can have the assessment. So we usually suggest a more readily available investigation, which is a long exercise test, also known as the McManus test. It is similar to our routine nerve conduction study, in which we stimulate the outer nerve and record the ADM muscle CMAP amplitude. And we will instruct the patient to perform voluntary muscle contractions for 5 minutes, and with resting for 3 seconds every 15 seconds intermittently to prevent the muscle ischemia. And we will record the CMAP amplitude of the ADM muscle immediately and every 1 to 2 minutes for up to 40 to 60 minutes, or until no further decline observed in CMAP amplitude. For the positive test, it means there is decrements in the CMAP amplitude more than 40%, over 20 to 40 minutes, or area decrements over 50%. And this test has a very high specificity, up to 100%, and sensitivity is around 70%. But this positive long exercise test can only help us to diagnose it is a case of periodic paralysis, but we cannot differentiate whether it is a hypokalemic, hyperkalemic, or periodic paralysis. So clinical correlation is important to differentiate the subtypes of the primary periodic paralysis. Other tests we can consider, for example, for diagnosing hypokalemic periodic paralysis, we can offer a provocation test by administering insulin and glucose to induce hypokalemia and induce paralysis. But it is dangerous, because it may cause life-threatening arrhythmia and hypoglycemia, so we seldomly perform in our clinic and in our usual practice. Another test we can consider is muscle biopsy. For hypokalemic periodic paralysis, for muscle biopsy, it may show reticular changes over here, or some tubular aggregates over here. But these findings were non-specific. It may present in other types of periodic paralysis. And of course, it is important to exclude secondary causes of hypokalemia or hyperkalemia. For hypokalemia, it is important to exclude phytotoxic cause, Crohn's disease, renal tubular acidosis, or drug causes like potassium-depleting diuretics. And for hyperkalemia conditions, we have to exclude Addison disease or some potassium-sparing diuretics. And this table shows the diagnostic criteria for hypokalemic periodic paralysis. The patient should have 2 or more attacks and with a documented hypokalemia at presentation, and with 3 out of 6 of the following features, which includes the onset at first and second decade, acute duration more than 2 hours, maybe up to a few days, with positive triggers, for example, high carbohydrate diet, rest after vigorous exercise or stress, and with clinical improvements after potassium supplements, and patients see any positive family history or genetic confirmed mutation or a positive lung exercise test. And our patient actually fulfills this diagnostic criteria, in which he had repeated attacks since the age of 13, and he has documented hypokalemia at presentation. And the onset is at the first decade, and he had the attack duration up to a few days, and he had clinical improvement after correcting the potassium level. And the lung exercise test for our patient is positive. And already we have excluded secondary causes of hypokalemia in our case. In our case, our patient did not demonstrate myotonia, either clinically or in the EMG examination. And for case of hypokalemic periodic paralysis, sometimes the potassium level may be severely low, that it may cause ECG changes or cardiac arrhythmia, which we have to pay attention to. This diagram shows the typical ECG changes for cases of severe hypokalemia. For example, there may be presence of small P wave peak, prolonged PR interval, an ST segment depression, a small T wave amplitude, and a prominent U wave after the T wave. So we have to pay attention to some specific ECG changes. And this is the table showing the diagnostic criteria of hyperkalemic periodic paralysis. Compared to hypokalemic periodic paralysis, there are some differences, including the acute attack duration is usually shorter compared to hypokalemic periodic paralysis. This is usually lasts within 2 hours. And there is commonly myotonia presence in cases of hyperkalemic periodic paralysis, sometimes up to 80% of the cases. And while the other diagnostic criteria is similar, more or less similar to the hypokalemic periodic paralysis. And for the Andersen-Tawil syndrome, as I've just mentioned, the patient may have characteristic face like wide space eyes, some low set ears, small mandibles, or for the toes or fingers may show some toe syndactyly or cynodactyly of the fingers. And the patient may have cardiac arrhythmia, for example, prolonged QT or ventricular ectopics. So we have to monitor the ECG for any changes. For the treatment, it mainly divides into lifestyle change and pharmacological treatment. For the lifestyle modifications, we will advise patients with hypokalemic periodic paralysis to avoid high carbohydrate diets, alcohol use, strenuous exercise, or stress. Patients may benefit from smaller but frequent meals or a low-salt diet. For hyperkalemic periodic paralysis, we advise the patient to avoid potassium-rich food, fasting, strenuous exercise, co-exposure, or medications that may cause hyperkalemia. And patients may benefit from carbohydrate snacks. And for the acute onset of limb weakness, mild exercise, for example, shaking arms or working around, can prevent full-blown attack of paralysis. So it is important to educate patients the mild exercise if they experience limb weakness as presentation. For the pharmacological treatment, it's divided into abortive treatment for the acute attack and prophylactic treatment to reduce the attack frequency and severity. For the acute treatment, of course, it is important to correct the hypokalemia or hyperkalemia status by medication. And continuous ECG monitoring and subsequent potassium measurements or monitoring is mandatory for the treatment for hypo or hyperkalemic condition. For the preventive treatment, we recommend use carbonic anhydrase inhibitors. Dichlorphenamide is the only FDA-approved treatment for primary periodic paralysis. But this dichlorphenamide is not available in our HA drug formulary. So we replace it by acetazolamide, which is another carbonic anhydrase inhibitors, also recommended use by some studies. And it helps by promoting the calciuresis and increase the urinary bicarbonate excretion, and leads to metabolic acidosis and reduce susceptibility to periodic paralysis. And the side effects include paresthesia, fatigue, cognitive disturbance, or renal stone formations. For the second-line pharmacological treatment, we can consider aldactone, eplerenone, or triamcinolone for hypokalemic periodic paralysis, or thiazide used for hyperkalemic periodic paralysis. And for the Andersen-Tawil syndrome, it involves multidisciplinary approach. It is important to have regular cardiology follow-up for any cardiac arrhythmias. And with it thus, we can consider medications like flecainide or imodrone for cardiac arrhythmia. And ICD implantations is reserved for those with symptomatic arrhythmia. And this table summarizes the acute treatment and the chronic treatment for 3 types of periodic paralysis I've just mentioned. So for the prognosis, it varies among individuals. For hypokalemic periodic paralysis, untreated patients may experience fixed proximal weakness or atrophy after repeated attacks. Like shown in this photo, this patient has marked muscle atrophy over the thigh muscle, over the hamstring muscles, and which may interfere with daily activities for this marked muscle weakness or atrophy. And several deaths are reported, mostly related to aspiration pneumonia or inability to clear secretions. And for hyperkalemic periodic paralysis, patients usually remain asymptomatic between attacks, and life expectancy is not affected. And as the patient may have myotonia clinically, medication used like mesalazine or lamotrigine can help to relieve the symptom. So in conclusion, primary periodic paralysis is a rare autosomal dominant genetic disorder involving the muscle sodium, calcium, or potassium channels. It can be diagnosed by genetic test, but we also recommend a long exercise test, which is a more easily available and simple investigation. And And of course, clinical correlation for the clinical symptoms is important to differentiate the subtypes of periodic paralysis. And for the management, we will recommend patients to avoid triggers and pharmacological treatment. For example, diclofenac or acetazolamide can be helpful for as the preventive treatment to prevent the attack frequency and severity. So this is the end of my presentation, and thank you all for attention. So do you have any questions? You can type in the chat box. So there's questions. For myopathies, reflexes usually preserved until very late stage. For clinical examinations for myopathy, yes, typically the patients may have hyporeflexia or areflexia, especially when the muscles are atrophic or at the late stage. Sometimes at the early stage, the reflex may be preserved without significant muscle atrophy or significant weakness. So the next questions, may I ask, did patients have muscle atrophy despite never having periodic attacks? Actually, our patients have repeated attacks since the age of 13. But up to our investigation or our examination upon admission, our patient did not have muscle atrophy. But if he had repeated attacks in the future, maybe muscle atrophy may present, or maybe he may have fixed muscle contractures.
Yeah, maybe I have some supplementation. I'm Dr. Lee, okay, neurologist from North District Hospital. One of the medical students asked us, why did the patient have muscle atrophy in I think a chronic periodic paralysis? In my patient, it doesn't have any muscle atrophy. But if the patient remain left untreated for over years, many patients with periodic paralysis may develop adipose tissue deposition or fatty tissue deposition in the muscle fibers, and that's causing muscle atrophy. And if you perform MRI scan of those muscles, you can beautifully demonstrate fibrofatty tissue infiltration. Okay. And it can end up with permanent muscle weakness. So we have to remind the patient not to develop and receive regular medication to prevent attack of periodic paralysis.
Okay, thank you, Dr. Lee. So is phagotoxic periodic paralysis is a kind of hypokinetic periodic paralysis. Actually, it is we have to differentiate these two, because for our case, specific for hypokinemic periodic paralysis, it is assumed to be a genetic basis, autosomal dominant genetic disease. And of course, we have to, as I've just mentioned, we have to exclude secondary causes of hypokalemia. And phagotoxic cause is quite a common cause for secondary causes of hypokalemia. And the treatment is totally different between these two types of paralysis.
Yes, some supplementation of phagotoxic periodic paralysis. In fact, it's relatively common in Asian population. Okay, not also common in Hong Kong. I think it's more common than a hypokalemic or hyperkalemic periodic paralysis in Hong Kong. The mechanism is due to phagotoxic causes, usually related to Graves' disease. and causing some chronopathy, leading to a hypokalemia during acute attack of muscle weakness. The treatment is during acute attack, you have to correct the plasma level of potassium because the patient may develop quite profound hypokalemia and may end up with malignant arrhythmia and also a sudden cardiac death. So during acute attack, we have to monitor the potassium level carefully and replenish the potassium level. And then also I need to treat the thyroid status because the patient is suffering from hyperthyroidism. Usually the patient needs anti-thyroid drugs such as gabapentinoid and also a propranolol. And when the patient use thyroid, after that, the patient must receive a definitive treatment such as radioactive iodine to prevent the recurrence of hyperthyroidism and also body paralysis.
One of these. Any questions? Another one. Which one? Another one. Oh, it's different. And for hyperkalemic PP, or you mean for the acute attack for acute episodes of hyperkalemia, and of course Ventolin can be used for correcting the hyperkalemia level, and other medications for correcting hyperkalemia, for example, resonium can also be used, and for example, Lasix, it may help, but it may cause other electrolyte disturbance other than correcting the hyperkalemia, and in which we in our clinical practice we seldom use just Lasix merely to correct the hyperkalemia. So I may ask why acetozolamide effective for preventing hyper-PP, and why acetozolamide is effective for preventing hypo or hyperkalemic periodic paralysis. I think for this, like our slides, for the mechanism, it is a carbonic anhydrase inhibitors, in which it can promote the calciuresis and to cause bicarbonate excretion on the body and lead to metabolic acidosis. And we will cause our potassium channel, calcium channel, less susceptible to the attacks. So I think it is the mechanism. Explain. I asked about CMAP. It is it is a compound muscle action potential, which is a component when we perform a nerve conduction study, mainly to check the muscle amplitude. Is it amplitude? Yes.
Yeah. Okay. Yeah, I think if this is the routine nerve conduction test. We stimulate the nerve, such as outer nerve, and record the muscle action potential over the ADM usually. That is the adaptive digital minimum. And if the nerve function is intact, you will demonstrate normal amplitude of muscle action potential and also the motor conduction velocity. And in patient with periodic paralysis, I mean during acute attack, the muscle action potential or the CMAP will decrease because of the membrane inexcitability. Even though you stimulate the outer nerve, but the membrane inexcitability causes reduction in the CMAP motor response. Okay, this is the rationale of long exercise test. But after attack, I think the CMAP or the motor amplitude we return to normal.
Okay, and one more question. Will the reflex be affected in acute attack of periodic paralysis? Yes, it may. For acute attack, it may present with hyporeflexia or even areflexia, but not in our case. Our case, the patients have normal reflex, probably because he is not in the acute attack, because after admission, he already had muscle weakness or symptoms for 3 to 4 days. So not in the acute attack.
Yeah, for the reflexes, because paralysis is the kind of tendinopathy affecting the muscle, you can consider it is a kind of a low motor neuron disorder. So the reflexes can be normal in between an attack, or it can be depressed or even absent in a severe attack or in very long-standing paralysis with muscle atrophy. The muscle reflexes can be reduced or even absent. But it couldn't be a hyperreflexia because it's a low motor neuron issue.
So if there are no more questions, then this is the end of our presentation. And thank you all for attending. So, okay, thank you.
Yeah.